Dear colleagues, thank you very much for still being here. This is the last part of this Congress, and I would like to thank the organizing committee for the invitation to this wonderful Congress in Athens. So, the PSA test dominates the urological diagnostics in several years. And even though it's not actually the topic of this presentation, I would spend some words for the PSA screening, as it remains one of the most controversial topics in the urological literature. Well, we have, after many years of experience and many trials, enough evidence for some statements. So we know PSA screening is associated with more localized and less aggressive disease, but also with minor and major harms for our patients, including impotence and incontinence. And the Cochrane review of 5 large randomized trials has shown no prostate cancer-specific survival benefit for the screening group. Only the European study could report a significant reduction of prostate cancer-specific mortality in a predefined group of patients aged 55 to 69 years. And we also know, after 13 years of follow-up, we need less men to screen and to treat in order to avoid the death of prostate cancer than women needed to be screened in the breast cancer trials. So, how can the PSA test be useful in the pretreatment setting? First of all, it is important for the risk stratification of the patients. If a patient has a low-risk disease, then he has to have a PSA below 10. If he has a PSA between 10 and 20, he has an intermediate risk disease, and if the PSA is more than 20, then he has a high-risk disease. The American guideline goes further and subdivides the low-risk category in a very low-risk subgroup and the intermediate risk category in a favorable and in an unfavorable subgroup. And one of the criteria for the very low-risk group is a PSA density of less than 0.15. For the favorable intermediate risk subgroup, the PSA less than 10 and the Gleason score 7A, or PSA between 10 and 20 and Gleason score 6 are the criteria. For the unfavorable intermediate risk subgroup, the PSA doesn't play a role. How can the PSA test guide our staging before treatment? So, regarding the local staging, the guidelines recommend a multiparametric MRI of the prostate if the PSA is above 20, or if it is between 10 and 20 and Gleason score is 7B or more, or if we suspect locally advanced disease. MRI is not recommended for low-risk patients, although it can sometimes be useful, for example, before nerve-sparing surgery or before brachytherapy, as we heard before. Regarding the lymph node staging, so the N staging, although CT and MRI have a low sensitivity, they are recommended by the guidelines if the PSA is above 20, or if it is less than 20, but we have a Gleason score of 7B or more, or again, if we suspect a locally advanced disease. The surgical staging, so the pelvic lymphadenectomy during radical prostatectomy, can be omitted if the PSA is less than 10 and the Gleason score 6. Regarding the staging for distant metastasis, bone scan and cross-sectional imaging are recommended if the PSA is above 20, or if PSA is between 10 and 20 and we have a Gleason score of 7B or more, so 4 plus 3 or more. But we have to know the bone scan positivity rate is very low if the PSA is below 20. However, we have to consider it if Gleason score is 8 or more, or if we suspect locally advanced disease, even if PSA is less than 10. While the whole body MRI is more sensitive and more specific than other modalities, but it is more expensive in any case and less available. So that is what the guidelines recommend. But there are several new imaging modalities that they search their place in our diagnostic pathway. For example, Curlin PET-CT is more specific than bone scan and MRI for bone metastasis. Can also detect visceral metastasis, but it misses lymph node metastasis in a high rate. The fluoride PET-CT is a very good examination for bone scan, for a bone metastasis, but it misses lymph node and visceral metastasis. And the latest and more promising development is the PSMA PET-CT, which seems to have the highest sensitivity and specificity among all imaging modalities, but we have to know there are still limited evidence, limited access, and very high cost, naturally. So the question is, do we always need a very accurate staging before initiating local therapy? How often would this additional information through an expensive examination change our therapy concept? And is there any obvious clinical benefit for our patients? And we have to consider, again, the still very high costs of these new imaging procedures. Well, we definitely need well-designed trials to answer these questions, and until then we can only use these modalities on an individualized basis, for example, using the PSA level. If we have a young patient with a very high PSA and no evidence of metastasis in the conventional staging, imaging, then we have to consider the PSMA PET-CT, and that is what we do in our department. Again, another use of the PSA is as a part of nomograms or risk calculators that really offer good predictive accuracy for many clinical issues as lymph node involvement, seminal vesicle invasion, or extracapsular disease extension. I could mention the Briganti nomogram, very well known for lymph node involvement, or the Partin tables, or the MSKCC nomograms that incorporate PSA and other parameters to estimate the risk of lymph node involvement, seminal vesicle invasion, and extraprostatic extension. And the nomograms could help us to avoid unnecessary treatment, pre-treatment imaging, and to counsel our patients. And the PSA level before treatment is important for the prognosis of the patients. As we know, it is an independent predictor of response to all forms of therapy. And we also know that patients with the PSA level less than 10 before therapy are most likely to respond to a local therapy. And there is some evidence that the PSA velocity before treatment is also a predictor of prostate cancer specific and overall mortality following therapy. There are actually two trials from the D'Amico group, one for patients undergoing radical prostatectomy and one for patients undergoing radiation therapy, who show that patients with a PSA velocity of greater than 2 nanograms per ml per year before treatment have a worse outcome. But there are other trials that cannot support this statement. And finally, I come to my conclusions. The PSA test remains the main tool for prostate cancer screening. It is substantial for the risk stratification of our patients before any treatment, before definitive treatment. It is of main importance for choosing the appropriate radiologic staging. Nomograms that incorporate PSA are useful tools for patient counseling and for choosing the right diagnostic and therapeutic approach. And the pretreatment PSA level has a prognostic value for patient outcome following therapy. So thank you very much for your attention.